Hello and welcome everyone to this webinar on FASD and Cannabis presented by Dr. Mela and Dr. Deji Ayonrinde. My name is Malou Gaber and I'm a bilingual project assistant at Health Nexus. So it seems like we have a majority of people who work with individuals with FASD, and that's the reason of their presence to the webinar. We also have some people with the lived experience caring for people with FASD. Right now, it's looking around 89% for professionals and 20%, 25%, because it's a multi-choice answer. So 25% also have lived experience caring for someone with FASD. So I'm getting it. So Health Nexus oversees several provincial initiatives relating to FASD. We allocate subsidies every year to over 40 support groups for individuals with FASD and their families. We designed an online training for service providers from various sectors, including healthcare and nursing, education, mental health and addictions, justice and corrections, and community and social work. And lastly, we manage the provincial FASD website, fasdinfotisaf.ca, where you can find recent and up-to-date information about what's happening, learn more about resources and tools, and find out services available in your local community. I'm going to go over a few house rules. So we will answer questions after each presentation. Please ask your question in the Q&A section. Remember not to use identifiable information when asking questions. Before we start the presentation, I would like to begin by doing a land acknowledgement. Health Nexus is located on territory that for thousands of years has been the traditional homeland of the Anishinaabe, Wendake Nayawantsayo, Haudenosaunee, and more recently the Mississaugas of the Credit. We're proud to take our part in the Dish with One Spoon, Wampum Bell Covenant, an agreement between the Haudenosaunee, Anishinaabe, and allied nations to peaceably share and care for the lands and resources around the Great Lakes. Health Nexus team members are grateful for the opportunity to partner with Indigenous people across Turtle Island and to work on this territory. Today, we are welcoming Dr. Mela, a professor of the Department of Psychiatry and the Director of Forensic Behavioral Science and Justice Studies. Mansfield's area of expertise focuses on forensic psychiatry. He's a diagnostic research lead for CanFASD and a recent recipient of the Ivor and Joyce Graham Small Indiana Professorship in Psychiatry. In his clinical role, he provides consultations at the Saskatchewan multi-level security forensic psychiatry facility, and his expertise is often drawn upon in court. We're also welcoming Dr. Ayonrinde, who earned his Bachelor of Medicine and Bachelor of Surgery, MBBS, from University College Hospital in Ibadan, Nigeria, and residency training in psychiatry was at the Bethlehem Royal and Maudsley Hospitals in London. He earned a Master's of Science in Psychiatry, Theory and Research at the University of London, a Diploma in History of Medicine from the Society of Apothecaries, and an Executive MBA from Imperial College London. He's a Fellow of the Royal College of Psychiatrists and an International Fellow of the American Psychiatric Association. I'm now going to hand it over to Dr. Mela and stop sharing.
Thank you so much, Malou, and welcome everyone. I'm going to start as usual in this kind of new world of technology by sharing my screen. So I am really pleased to present to you what we think is quite a unique area. I welcome you from wherever you are. I'm speaking from Treaty 6 territory, the land of the Métis here in Saskatoon, Saskatchewan, where we have been conducting some work around FASD and cannabis. And just a big shout out to Health Nexus. Thank you for your promotion of this type of work, for focusing on knowledge mobilization, and really being the eye of so many who want to see how to help individuals who need the necessary help. I'm also excited to share this stage with my colleague, and I always joke that when I grow up, I want to be like Dr. Ayonrinde. So this is a great opportunity for us to collaborate on things that we're very passionate about and very sensitive issues for sure. So as indicated, the topic is generally about cannabis and FASD, and I'm going to be focusing on a particular experiential and perspective research that we've been carrying out, actually, interestingly, during COVID. So there's a lot of lessons that I'm going to be sharing with the participants on the cannabis use among adults. And these adults are persons who either identify as having FASD or who have a diagnosis confirmed of FASD. I'm pleased to tell you that you are the first audience to actually receive this fully analyzed results. So we are working on a manuscript right now, and hopefully this will not only have knowledge implications, but will actually help you in your practice and your understanding. What I'm hoping to cover, as I mentioned, is a perspective. So it's really interviewing people who have an experiential contribution to the topic. It's not a lab test, it's not about company, it's not about what other people think. This is about individuals and what their experience is. So in that experience, I would like to cover how cannabis is used by this group of individuals, what benefits that they tell us and their loved ones tell us, and how consistent those accounts are, and what negative outcomes of using cannabis look like from their own experience. And because the research started after the legalization, we also had an interest in trying to understand the impact of legalization, which came on the big day on October 17, 2018. I would have wanted to present to you some of the things that we talked about in terms of how treatment centers approach individuals with FASD who are using cannabis, but this is a revolving and evolutionary area that we haven't yet completed the analysis. For most people, this will not be any new information, but is worthy of articulating that the aspects of a diagnosis of fetal alcohol spectrum disorder, even though the name and terminologies have changed, relate to the consequences of prenatal alcohol exposure in individuals who manifest a combination of challenges and strengths. It is important to recognize that individuals with FASD do indeed have some neurophysiological and neuropsychological vulnerabilities, and that has been covered in multiple research to indicate the damage that the alcohol causes to certain brain domains. Specifically, there are challenges with affect regulation, with attention, achievement in school, with memory and things like executive functioning, and a wide range of complications, including multiple comorbidities in the realms of substance use and the realms of mental disorder. So really relevant to the audience today. One of the things that we're discovering in substance use disorders in relation to this topic, and something that we have seen through our research that I'm presenting to you, is the specific identification by individuals to specify that the role of the substances they're using actually is aligned with certain deficits that they have. So this is important. And what do we know so far in the combination between individuals who have FASD and cannabis? As you know, the Canadian cannabis survey has been going on for a number of years, and so we can see what is happening year by year, and there is at least some evidence that the legalization is increasing the use of cannabis, and this has been reported in other places, especially in the earlier part of the legalization, whether it's celebratory or it's actually the freedom and the access that is improved. That is yet to be confirmed, but there is obviously some impact in legalization. And so for cannabis and people with FASD, this is relevant because we're dealing with an atmosphere where their cognitive deficits could be exploited when it comes to even things like access. So the data that we have right now, as you can see on the slide in front of you, is that compared to the Canadian general population, and the research is a little bit different in terms of how they arrived at their numbers. So anybody above the age of 15, and in the last 3 months, Statistics Canada in 2020 identified 16.7% of those individuals to be using cannabis. We've been collecting data in those who have been diagnosed with FASD through multiple clinics, at least 30 of them around the country in Canada. And there is a question within the data to inquire of among adults, how many of them are actually using cannabis. And as you can see, the number is more than double the Canadian population. There's a study that was published in Germany where 20% of the population in general use cannabis, but 29% of the FASD population in Germany reported using cannabis in a very small sample. So you can see there is just something that represents an overuse of cannabis among this population. So is it good? Is it bad? We are trying to explore that through this research. And we have a very tiny sample of 5 where Coren and his colleagues reported an improvement in disruptive behavior when CBD, which is one of the prototypes present in cannabis. By the way, you will hear me use cannabis, cannabinoids, pots, which was the term we used in our study to simplify the language. So in this particular study, we had about 5 individuals that had disruptive behavior, diagnosed with FASD and treated with CBD, and they had an exceptionally good response, even though the sample was very small. So the research we undertook actually is part of what we usually do, developing our research question from a practical lens. So we, through the CanFASD, and if you have not heard about CanFASD, I strongly encourage you to go to the website. There's lots of material there. There's lots of research that has been done. You can ask lots of questions and you get lots of answers. So one of the key components of the CanFASD, which is a research network across Canada with 9 provinces contributing to this work, is that there is a family advisory committee, which is representative of loved ones who care for individuals with FASD. And they've been asking us questions about, either the adverse impact of FASD on their loved ones or the beneficial things that they're seeing, and they wanted to know what will the research tell us. And so this is where we started, and we built up a research team, which I must say is probably one of the most crucial things that researchers need to consider doing. So we have actually individuals with lived experience diagnosed with FASD as part of our research team. We have caregivers who have guided and shielded and directed how this research is done. We have frontline staff who work with individuals with FASD as part of the research. And we also have researchers and clinicians who share their own perspective all around the same table. In fact, we just met yesterday to gather more insight into this work that we've been doing. The research, as I said, was kicked up to have both an online survey approach and a focus group approach. So far, and we focus on adults, obviously, and so far, For the adults that completed the survey, and I'm going to show you where they are all from within the country, we have 116 of them that have completed, and we've conducted focus groups with 15 adults with FASD. We also have caregivers and frontline staff amounting to 79 who have completed online surveys with similar questions, but of course phrased to them to give us their perspective of what they think about cannabis in their loved ones, where the adults gave us their perspective about what cannabis has done for them. Important to look at the demographics. You see that at least more than 50% of the sample is male out of these 116. In terms of age distribution, more than 50% are younger, between the age of 18 and 30, with the average age of first use of cannabis at 15. And as you know, most of the drug of use, including tobacco, are initiated in earlier ages, but 15 is obviously the one that we are finding in this population. The study was in Saskatchewan, and we had a lot of support in Saskatchewan. As you can see, the representation across the country, at least 9 of the provinces and territories are represented. I'm pleased to say Health Nexus is in Ontario, and you helped us with at least 15% of the sample, which is great. We didn't have any from some other territories because of ethics issues of overcoming that. So we hope that we'll be able to get to some kind of conclusion in terms of that. Some of the demographics that we found and asked the adults, remember I'm giving you the perspective of the adults, very soon I'll compare the perspectives of the adults and the caregivers so that it can give you an awareness of where people are seeing the benefits and the risks of cannabis use and what lessons can we learn from that. We asked them about their educational level, and as you can see from this result, 37% of them had some high education and 43% of them had completed their education and got their GED. So not a bad population when it comes to education, but clearly not advancing to degrees and university and that. A slightly disappointing result, obviously, is the deficiency in employability. Not surprising in that these disorders do cause functional abnormality, and therefore to see that the highest level of kind of involvement is part-time and odd jobs at 22%, while 35% were not working at all, is representative of what we usually see clinically. And that's why these individuals need a lot of support to guide them towards improved functioning and to try and support their own advancement. Now, many of you will be asking about the diagnosis. That was not an easy one. As you can imagine, that we are doing this more or less self-reported. In general, in most research, the different diagnoses represent just a tiny adjustment to some of the criteria, and we could address this in the Q&A, but I think most people who know about FASD recognize the different names that have been attached to the diagnosis over the years since 1973, and the changes that have brought that on to the extent that in Canada, our guidelines came into effect in 2005, and they were reviewed in 2016, introducing a new concept where FASD has now become a recognized diagnosis compared to things like FAS. Anyhow, in our sample, we provided a range of diagnoses, and we saw quite an unusual response whereby FAS, which usually tags around 13 to 15% of populations of people with FASD, FAS in this survey was endorsed by 60% of the adults. We think the reason has to do with more or less language, time of diagnosis, age of diagnosis, and the concept of the name, whereby most people just identify themselves as FAS. FAS is a very strict criteria, medical criteria, so it's surprising that the individuals endorse that. All to say, though, that people who were part of the survey were engaged in services that support individuals with FASD. In terms of the prevalence of use, this was interesting for us because our advertisement more or less self-selected and brought quite a number of individuals who are either using or have used FASD. So as you can see from this bar chart, that out of the 108 responses we got on the question, do you currently use cannabis? Only 16% indicated that they did not. And out of the 113 responses in terms of have you ever used cannabis, only 4% indicated that they have not. So beginning to tell you that although slightly biasly pulled together, majority of individuals that we're talking to have used cannabis, and so their perspective in that context, I think, is a reasonable one for us to take seriously and develop some approaches towards those. We did ask a lot of questions about the pattern of use, and so to show you, starting with the form in which the cannabis was used, without question, the smoking, 81% of individuals who responded to that indicated that they use the smoking route as the main way. It wasn't exclusionary, as you can see that there are more than 100% responses, with edibles coming next to it, and interestingly, having others who are using like the oils and the tincture of the cannabis as their method of use. For the most part, the quantity used per week was broken down into different amounts in grams. And as you can see, 1 to 5 grams per week was the one most endorsed at 36% of the adults who use cannabis and have a diagnosis of FASD. Interestingly, others, this option included others, which meant they could not quantify the grams of dried cannabis. So this was where things like oils and tincture were included. We're very interested in the time of day of use because it speaks to the reason for use in an indirect way, but also opens up any intervention or any support that we would like to provide for individuals. So as you can see, from 4 p.m. to 12 midnight was probably the most concentrated period of use, even though majority of people use it 3 times a day, as you can see in this particular pie chart. But 4 p.m. to 12 p.m. was when they endorsed using most people, this is when they use cannabis the most. Using 3 times a day was actually occurring in 50% of the individuals, and we had a variety of frequencies, including 7% of people who used cannabis less than once a month. We were also interested in terms of the different components of the tetrahydrocannabinol and the cannabidiol content of the cannabis they were using. As you can see, 25% of the bat indicated it did not matter to them and they did not know what the combination was. But clearly, higher THC, either in terms of its pure form or when combined with low CBD, as you can see in the 4th and the 6th bar charts from the top, accounted for the most amount of use. So clearly a higher quantity of THC, and with 10% using pure CBD. And most of our research work actually was initiated by those who are asking questions about CBD in a positive way and asking questions about THC in the negative consequences that it gave to their loved ones. I use a few comments just to buttress the point of what it was that these different contents highlighted. This is a participant who said, the business, the lights, and so on, people moving, people touching me, it was just too overwhelming. I use a strong indica with a high THC content. It allows all that input to come in. I'm able to process it without having a meltdown. So this was in the context of the focus group information that we're asking people to tell us about their use of different contents and what they chose. Another one said, I used to smoke about 20% THC, which is quite potent. I've cut down to 10 to 15%, which is more manageable. It's like a glass of wine a day compared to like a couple of shots of vodka. So we begin to see that there may be room to use this kind of comments in trying to assist, whether in harm reduction or in changes of substitution, or even reducing the quantity of individual using. Speaking about the pattern of the different content, THC and CBD, we had multiple participants speak about how high the content of CBD was helpful in giving them energy, and so therefore using most of it during the day. We had some others who said the indica was more helpful for nighttime, and so used to calm their mental state and to improve their sleep. We are aware, obviously, that some of the responses, especially in our focus groups, indicated that they were not really looking into the content and therefore haven't really separated which one they were ingesting comparatively between the two. In terms of what individuals reported for the positives and the negatives, having looked at the pattern of use and recognizing that a lot of people actually with FASD use it, it was interesting for us to ask also about their quality of life. Now, remember in this slide that you're seeing, the orange bars are for those who are currently using. As you recall, about 84% of them, and only 16% were past users. And the questions about the quality of life really is more or less around how the negative impact of life. So unhealthy days are qualified, activities that are limited, feeling mentally unwell, and feeling physically unwell. Even though not statistically significant, we found that those who are past users were reporting a worse quality of life compared to current users, which kind of stimulated our curiosity. And we found out through the focus groups that people were reporting an improved quality of life because they believed that they were dealing with the symptoms by managing it by using the current cannabis. Now, again, don't forget, this is their perspective, suggesting that they improve their quality of life by using the products that they were using, whatever the combination was. So that was quite interesting because we're interested in the quality of life. Now, this is where the results begin to get quite interesting. To orient you to the slide, think about the biological consequences of using cannabis related to experience of tension, relief of tension, relief of anxiety, improvement in sleep, improvement of depression. So those are the 4 different categories, as you can see. Then orient yourself to the colors of the bar. I know it's kind of a little bit confusing, but anywhere there is green is speaking to an improvement in the symptoms. So cannabis whatever product they were works well for tension, for anxiety, for sleep, for depression, by the percentage in green. So if we even stick to that alone, you see that the first bar on your left, which is the adults' responses, 78 of them, indicating that at least cannabis works in 75% of them very well, and a little in about 27%. So if we just stick with the green, while 73% of adults said cannabis works well for their tension and relief, only 51% of their caregivers and frontline staff indicated that it works well for tension. Anxiety seems to have equal responses, with close to 70% of the caregivers and staff reporting that cannabis relieves anxiety in their loved ones, and 75% of the adults indicating it did. The more differentiation comes in depression, whereby 69% of the adults felt that the cannabis products improved their depression, and close to 40% of the caregivers said it did. So this is to begin the separation, while recognizing that there is some benefit and some consequences, which I will show in a minute. But there was a statistical difference in the response of the perspective of the adults with FASD from their caregivers and frontline staff. We have some responses here to suggest that individuals with FASD, by the way, the first response where this individual says, my dysregulation has been since birth, with chronic gastric issues, hypersweating, chronic or severe nausea. I'm always trying to put out the fire. I hydrate throughout the day and the symptoms seem to be worse. Sativa has been a partner, suggesting the benefit in relieving all those physical concerns. And similarly, another participant talked about the role in appetite. And the last participant, IP2, indicates a person who was interviewed indicated that the product they were using was better than melatonin when it came to sleep. So we can see some of the benefits that people are reporting when they have used cannabis. And so in a way, some of this will be needed when we're talking about motivational interviewing. To the negative effects, this is where we are again orient yourself. On the left, 3 bars is really the responses by the adults. And on the right, 3 bars is the responses by the caregivers and the staff. And so if you combine the light green and the orange, which speaks to a lot green and a little or some problems that cannabis causes. So we focus on sleeping too much, eating too much, and having a short-term memory. And you can see that when you combine problems, a little and a lot, about 60% of the adults indicated that cannabis caused them to sleep too much, and about 70%, so this is 20 plus about 50% of the adults indicated that it caused them to eat too much, and memory problems were reported in about 70% as well. Compare that in terms of the perspective to the 3 bars on the right, whereby about 90% of the caregivers and staff reported that cannabis contributed often or occasionally to problems in their loved ones who used it to sleep too much, eat too much, or have memory problems. So that's an example of some of the disparity, but clearly it's not all about improving sleep and improving anxiety and depression. There was some recognized problems that both adults and caregivers mentioned. This begins to kind of fashion out in terms of how do we then develop a nuanced approach to individuals. Again, this is a representation of the recognition of cannabis products in improving impulsivity, hyperactivity, irritability, and behavioral problems like aggression, where we're getting responses such that the cannabis works well. This is the opaque or gray colors, as you can see, between adults and their loved ones, or works really well. So there's obviously some things that seem to be reported as beneficial, but there's still some other things that are negative. Just wanted to use some responses of adults to share with you about some of the improvements that they use. So for example, when it comes to sensory processing and social anxiety, this is an individual who was interviewed, and he said in the second column, I can't make Calgary stampede. The business, the lights, the sounds, people moving around, touching me everywhere, it's overwhelming. I can't do it. But if I use a strong indica with a high THC content, it allows all that input to come in. I'm able to process it without having a meltdown. So that's one example. And then the other one, in terms of socialization, I smoked with my mom for the very first time because of my diagnosis. Now we smoke together every day. It's a very common thing in our household. So it begins to talk about some of those things, about how the cannabis is used to address certain things. But of course, we mustn't forget the issue of the masking that is usually reported. Lastly, in terms of their perceived negative effect, we wanted to know what they thought about some of the things that we know in the literature, or some of the negative consequences like perpetuating psychosis, worsening aggression, contributing to behavioral problems, leading to withdrawal and reducing motivation. And again, problems being caused either a lot or a little, as you can see in the green and orange bars are slightly different. Recognize that not causing no problems is blue, and there's more blue on the adult side, which is on the left, compared to the caregiver side, which is on the right. We were fortunate to be able to inquire among some of the individuals who stopped using cannabis on what their reason was in a formal interview or in a focus group. And some of it has to do with the fact that they initially entered this because of peer pressure, so it wasn't a choice. So that's one example of being able to come out of it. Others reported that they had to drop out of school because of cannabis use, and that was intolerable to them. For those who are taking certain medications, for example, in this case, a tranquilizer called, or rather the person called a tranquilizer Valium, that this was counteracting the effect, and so they had to stop. There was some other kind of atypical responses. Said they did not have the expected effect of hoping to kind of get more benefits than risk, and so they elected for themselves to come out of it. And so this is a helpful thing that tells us, when it comes to motivational interview, that really presenting both the benefits and the negative consequences may be a useful way to promote and support people who want to come out. And then, of course, financial consequences will usually feed into that conversation. I'm not presenting all the impact of legalization, but it suffices it to say that legalization for some provided a safe access to cannabis and reduced some of the vulnerability factor of exploitation, which we know is very common in people with disability. It seemed to allow for a consistent supply of choosing between the combinations, which they couldn't do in a non-labeled way. And it seems to reduce the stigma that they felt for using cannabis before the legalization. So if we are to summarize some of the findings, we will say that there are some kind of FASD-related problems physical, biological, and social that individuals who use cannabis were telling us that they find improvements in when they use some of the products. Of course, we are not sure which one. Is it the THC, the CBD? So it's important for us to do. Suffice it to say that they talk about managing certain symptoms like self-regulation, trying to manage some of the impulsivity that they experience. But we found through this research that there is quite a range of individual variability in terms of these responses. Even in our focus group, there were contrary opinions by the people. And so people experience this very differently, not only in perception as we see in the difference between loved ones and adults, but also in the context of individuals themselves. In fact, not just individuals, but from one day to another. So somebody may find some benefits in getting sleep today, but the next day, the cannabis will keep them awake. So this is very common in the responses we got. Another lesson is that there is a place for healthcare professionals, especially physicians, to be enrolled in terms of the psychoeducation, but also in safety, because we believe that 25% did not even know what they were taking. That may probably be an underestimation of the numbers, but it's helpful to have education that suggests what, if any, of the two may be helpful for specific individuals, leading to some form of nuanced approach for administering and providing. Physicians will be very helpful in terms of education, or healthcare professionals, pharmacists, and the rest will be helpful in terms of drug interaction as well, and the different ratios, and obviously some of the movements towards helping those with FASD to discontinue using if we see an imbalance of the negatives from the positives. I mentioned earlier on that our research was really during COVID, so I'm sure for the most part, many of you who did research during that time will identify with the difficulty of recruiting participants. We use lots of methods to recruit, lots of support, but that was still not very sufficient to reach to our numbers and to cover the whole country, which provides a little bit of limitation. We actually went after those that we could identify who had never used cannabis, more than 4%, and that again was not very successful. It's helpful to note that some of our research participants actually discontinued the surveys for the reason of being triggered during the process. So what is the best way to sensitively collect information from individuals who are either trying to give up substances because of negative consequences, and here we are asking them questions about it and being triggered to crave or return to use? So these are important ethical questions during research. We learned also that although this is exploratory, we are unable to really confirm the perception or perspective that individuals are giving us of the benefits, medicinal or therapeutic, one way or the other. It will probably be done individually or done in more interview format. We know there are challenges with memory because of the deficits in FASD, and therefore self-reports will have to be viewed from that perspective. I'm concluding by indicating that this research is beginning to open a way for us to begin to think about the variance or the varied perspective and perception of loved ones and frontline staff from that of adults who are using cannabis. This is important because any attempt to provide either harm reduction or complete abstinence will require support from loved ones. And if they come from it from different perspectives, there may be some difficulties in actually actualizing whatever therapeutic goal or interest that is. So having joint sessions in psychoeducation, having groups speak to one another will be important to reduce some of the differences in perspective. This also contributes to the aspect of what should treatment center staff be using as support, not only listening to the adults, but listening to both the adults and their loved ones in terms of getting a more fulsome representation of what exactly happens. Motivational interview is a well-known part of substance use intervention, and we have seen that there are risks and benefits endorsed by adults and caregivers. As such, these lessons will be helpful for staff to introduce when trying to describe what exactly is going to be needed for individuals who have FASD that are either trying to reduce or to prevent themselves from using substances. Whatever is geared to be used should be tailor-made for individuals. I've talked about being nuanced, I've talked about individuality and the differences. And so I think this is really important to be able to do that, so that there may be some people that will benefit from low THC, there's some people that will benefit from CBD, and that has to be tailored differently. We need to introduce interventions that will likely replace the theme of self-medication and maybe target particular areas with activities for those who have a negative consequence that will replace this high-level use at a particular time. We think we have a lot of lessons to learn from those who have never used cannabis and have FASD, because we've not been able to get to that particular information. So as I conclude, I really want to thank a lot of the families that participated, the loved ones, the adults, and we were very fortunate to tag onto a grant that Dr. Amina Kapasi actually had through the Substance Use Association in Canada and CanFASD for their ongoing support. And these are just some references for you. And I think we have some time for Q&A. Thank you.
Thank you so much, Dr. Mela. I see we already have a few questions in the Q&A box. I'm gonna read the first one. Someone was asking how many people were in the survey. They were not sure if they missed the information or not.
Okay, so I put it there. Yes, you missed it, that there were 116 completed surveys. I believe we had somewhere around 20 uncompleted surveys that were not included in this as the surveys for the adults. We had 79 completed surveys for the caregivers and frontline staff who completed the online surveys. And we did have a table that showed 15 adults that we did focus groups with, and then 8 caregivers and 15 frontline staff that we did. I'm blocking on the name now. Focus groups together with. Thank you.
Another question was, how much did the cost impact their use and quality of life?
Yeah, so we could not establish in terms of the significance of that. This was not a question we asked specifically in the survey where we could have gotten quantitative data. But as I mentioned in one of the slides, during the focus groups, one of the individuals, or I think a couple of the individuals who discussed their abstinence or discontinuation, cost was a factor. And this was both before the legalization and after the legalization. So while we can't quantify how many people stopped because of cost and how much cost it was that made people stop, we know that it was mentioned that cost was a factor in helping people to make the decision to quit. How much it makes the decision to reduce, we don't know.
another question was, did you also look at the amount of caffeine and nicotine that they use, which would be heavily influenced negatively?
Yes, we do have the part of the survey that looks at other substances that they're using.
Okay.
Unfortunately, it was actually more or less in terms of the identifiers themselves rather than quantitatively. So you have to write it into the chart. We've not yet analyzed that. We are very aware that this is an important piece of the information because this research actually came out of a similar research that was done among internal medicine patients in British Columbia, where this type of questions were asked of them. And so the relevance of their treatment, whatever medication, whatever substances they were using, was very important. We are also aware that when you think about substitutionary interventions where people could use cannabis in place of other substances, this is an important question to ask. So we do not have like a full report to be able to share with you what is the caffeine use, the cocaine use, the other medication use. We do know from the focus groups that some individuals stopped using because it was counteracting the impact of certain medications, but we cannot tell you in quantity wise.
Thank you. Someone was just asking if the slides will be available. I don't know if you are okay with us sharing the slide after.
If you don't mind, I would need, as I said, there is an article that is being submitted on this research. I don't see any reason why not. I would just want to consult with the team, especially our lived experience persons, to ensure that they are okay with it. Again, I don't see any reason why not. So Malu, maybe we can have a conversation on how we can share with the participants after this. Yeah.
Absolutely. So we'll get back to you on the slides. And then we have another question. Was there any consultation to find the right combination and strain discussions?
Yeah, no, we deduce from the strain discussions about this by the quantity, and as the results showed, a number of people did not know about it. Others specifically knew their quantities. In fact, they essentially prescribed whatever they did, and as you can recall from the one participant who reduced the quantity of THC from 20% to 15 to 10. We think this is an important part of the knowledge mobilization, whereby recognizing that whatever the person is not taking is not the same, recognizing that the quantity can now be identified almost exactly, that if it's labeled, then maybe there may be some harm reduction as well as safe use of these substances, but it will be an individualized process. And I think why we think this is better individualized is some of the variabilities that we've seen from perspective, from use, from impact and effect and consequences. And as I said, it varies from day to day, not only in one person, but in the multiple people. So I would encourage families listening, as well as healthcare professionals, especially treatment staff in treatment units, to recognize this window, this door that is opening for the discussion around strain and content, because I think it's important when we can include it rather than the blanket, black and white, use or not use, to really begin to look at what is it that should be relevant for this person in use and what should be discouraging for use.
Thank you. Another question is, as we know, substance use rates increased during COVID. Do you think this affected your research?
That's a very good point. You know, I wish we had done this research before COVID and after COVID. We want to kind of bet or not, but of course we have no way of proving it, right? So why we think is not is based on just what we are hearing. I mean, yes, 86% were currently using. The data from the data form, which is all clinics, identified 46%. We're very aware in speaking to our frontline staff. In fact, I remember this conversation I had with a frontline staff in Edmonton and said to me, well, do you expect anybody with FASD to not use cannabis? So this is what is anecdotal, is not really scientifically proven. So we think that the rates are quite high. Now, add to that, that our method of advertisement, unfortunately, selectively pulled people who would likely use. We actually went after those who have never used, and it was, as I said, it was really difficult. So the ideas we had from our community members was advertise in religious settings, colleges and churches and mosques. Maybe there will be people with FASD who will come forward who have never used because of their religious learning, but we were still not able to pick up people. So, there's no way of proving that it was COVID that increased the quantity of our result. We know that the numbers are high, anecdotally and from the data form, but there's no way of proving it. So it's a good question that I think we need to consider going forward.
Another question, do you know if there are any studies where there is a control of dosage and strains and distributed by physicians?
Not to my knowledge. I know Dr. Caroline McCollum does a lot of work out of British Columbia with a team of other doctors, but not specific to FASD population. As I said, this study came out of what Dr. McCollum had done with internal medicine participants, but we do not have prescribable cannabis to people with FASD that has been analyzed. Our goal is obviously to get there. We actually had been trying to work with a particular company here to focus a lot on the impact of CBD in a controlled way, to almost do a double-blind control study. But as you can imagine, there are multiple ethical and challenging issues in doing that. Hopefully we will get there. We have been talking to a company about doing that, but we want to be as independent in the results and its dissemination as possible. So long way of saying I am not aware of any study that way. Thanks.
One last question. Since more families are exploring CBD oil use for children to reduce disruptive behaviors, based on this research, do you expect there to be an upward trend of cannabis use in the future?
It's difficult to predict. As you can see, we have benefits as well as risks. I mean, these are all subjective reports. So when we start getting to objective reports, like the second to the last penultimate question I asked, do we have strain and quantity prescribed to be able to evaluate the risks and benefit? When we get there, I think then we will be in a better place to be able to answer the question. Our goal at this was to begin to critique the black and white approach, but also to hear as a foundation from those who are in the thick of it, frontline staff, loved ones, and adults, to say, what are you hearing from your life? What are you hearing? Then that would guide us to be able to look at the question, because I think even if the use increases, the use and guidance from healthcare professionals will still need to be nuanced. I struggle to imagine a blanket advice for everyone, but we have to wait and see.
Thank you. Thank you so much for your time in answering the question. We're now going to move on to Dr. Ayonrinde's presentation.
Thank you.
Thank you very much, Dr. Mela. Can you hear me?
Yes, very well.
Thank you very much. Well, thank you for the earlier presentation. And as with the introduction earlier, my name is Deji Ayonrinde. I'm an associate professor of psychiatry and psychology at Queen's University. I have a background both in addictions and psychiatry, and provide a service within our local area here for cannabis consultations with regards to risk management, mitigation, and also concurrent use of cannabis products with a whole range of health-related disorders. Now, my focus is going to be on safety considerations, and I'd apologize in advance if some of the content appears extremely basic. Perhaps we can be more challenged during the Q&A session. And what I'll try to do is pitch for a mixed audience of knowledge, but certainly we can push detail during the Q&A session. Now, cannabis has been legalized in Canada for both medical and recreational purposes, and it means the access to cannabis and cannabis products, the routes of use and indications and motivation for use would be different for different people. A lot of people who actually don't access cannabis through the medical routes still use it for medical purposes. And by that, I mean to reduce symptoms or experiences that may be causing them health-related distress. And recreational use across Canada, provinces and territories would vary with different age-related caps and means of access, but it's universally available across Canada. And that's a really important consideration if we consider the earlier presentation and the implications. So I'm going to start with the end of my presentation with some key points. As we heard from Dr. Mela, there's no single FASD presentation. There's a whole variation in symptoms and presentations, and each individual is unique. With that in mind, it makes it very difficult to generalize any statement. So what I'll be hoping to do is cover broad principles rather than specifics. To add to the complexity, there's no single cannabis. There's immense variation in plants, products, and preparations. But I'll actually argue or put it to you that with the passage of time, cannabis will be less the term we'll be using because there's no single cannabis. And when we refer to it, another way of considering cannabis is thinking of the term dog. Dog gives us a rough idea, but what breed? Is it a Chihuahua? Is it a Husky? Is it a Great Dane or a Border Collie? Because that is, again, shows how unique the different products are. Or another way of contemplating cannabis is like the word alcohol. We're talking of a weak beer or vodka, brandy, and a whole range of other fermented products in between. Or like the term car. What does that tell us? What vehicle is it? Is it a truck or a small mini? And that's a really important consideration anytime we hear the word cannabis, to allow ourselves probe in our thinking. What sort of cannabis or cannabis preparation is being referred to, and what are we referring to as cannabis? I'll be touching a number of things, and I think it's fair to accept that cannabis is consumed widely and broadly. There's a higher prevalence of use amongst FASD populations, and cannabis is now quite ubiquitous. So it's available, but it's also available through multiple routes, both legal, authentic cannabis products, but also illicit. And this further complicates some of our cannabis considerations because not everyone buys or accesses cannabis from legal routes. So I'll be touching on how to identify legal cannabis products, the online risks, issues to do with product designs, THC, CBD, and other cannabinoid labels, and the impact on toxicology. And that's so important because the presentation we've just heard, if people are going to be quantifying the THC contents, the CBD content, there's an assumption that they're getting it from a reliable, trustworthy source. And whatever's on the container is actually what is contained with the cannabis. So here's a Health Canada produced document, and it's really worth familiarizing with yourself with this, because choosing products that are authentic can also have an impact on how we understand the dosing, the THC content, CBD content, and the whole range of other properties of the cannabis products that's being consumed, but also help us gauge risks and manage risks better. And if we look at the left side container, so there's the standardized cannabis symbol, which now we're becoming quite familiar with. The shape with the cannabis leaf and the words THC written on. So that's a standard symbol. And if any product doesn't have that symbol on it, beware, it's not authentic. Now, we're aware that symbol's now being copied and put onto illicit products as well. So what else do we look out for with the packaging? Well, we'll look out for an excise stamp, and the excise stamp on the top bit, which is here, should give you the details of the province as well, or the territory you're in. So that's one thing, and it should not be damaged. Another thing to look out for would also be health warnings. And for licensed products, you'd have the health warnings in a yellow box, and the wording is fairly specific, and then some other details. And some of the other details in white boxes will be THC levels and CBD levels and so on. Now, licensed products, unlike the unlicensed ones, may carry heavier risk. Now, I'm not saying all of them will, but licensed products, unlicensed, may I clarify, illicit substance, cannabis may not have gone through the rigorous test process required. So may carry higher risk of bacteria, heavy metals, and so on. And this is really important as we consider people with health conditions who may be on medication and avoiding additional risks from herbicides, pesticides, and so on. Again, if we look at websites, to be aware that there are very specific websites, and I'd encourage each of us to be familiar with what sort of online presence is there for cannabis in each of our provinces, because it is quite different. And in Ontario, for instance, it'll be through the Ontario Cannabis Store. Why does all this information matter? I'll let you just take a few seconds to look at these images in front of you. So here are some illicit cannabis substances, but extremely attractive. And what they've done also is to use very familiar names to package products and label them. Many of these have been infused with cannabis. Now, whether the stated numbers are as stated, that's difficult to tell. But for instance, there's a well-known brand of snack here, and here's a variation of that snack, but infused with cannabis, not from the original manufacturers. And here it reads 500 milligrams. Or the Skittles here, which again isn't the product from the known manufacturer, reading 400 milligrams, and so on. So it is actually practically possible to consume the equivalent of multiple joints, extremely high potency, or quantities of cannabis in sweets, potentially tasty products that have been infused, but these are illicit substances, illicit cannabis products, and carry considerable harm and risk potential when we're talking people who may not be as discerning or with whom other risks of harm will be a concern. So just to be aware that in as much as there are some products out there, there's a whole range of access online and from other sources that people may be consuming. I'm going to be touching briefly on Canada's lower risk cannabis use guidelines, and more for familiarity, knowing fully well that this may not apply to everyone. And in some areas, it may feel rather basic, but still really relevant knowledge for all of us working with individuals with FASD, if not ourselves. And there's some evidence-based principles. It's got a public health background to it, and it continues to evolve with time. But this is something that we encourage everyone is familiar with, as will be the case with alcohol as well. So recognizing that there's no safe cannabis consumption, but same thing applies to alcohol and other things. Abstinence is safest. And not suggesting that abstinence is the only way, but the best way to reduce any risk of harm is zero consumption. And if you then do consume any products, to then consume in an informed way. And I'll be touching on these. So age, low THC, avoiding synthetic products, the risk with smoking, inhalation, frequency of use, driving, pregnancy, and avoiding combining the risk factors. Now, we're way more advanced in some of these considerations for smoking, for alcohol consumption at the moment. And as we begin to develop a cannabis etiquette, these are areas we'll begin to know more about. And research is ongoing. So as said, this isn't always practical or possible, but if you're going to bring the risk to total zero, abstinence is the way. Not practical for everyone, and surely everyone has a right to having a recreational life, and a number of people do access cannabis products for medical purposes. Delaying cannabis use till after adolescence. Once again, this is desirable because of the potential adverse health outcomes. And the emphasis here is more around the developing brain. A lot of this you may have heard over and over and over again, so I wouldn't be too repetitive about it. But these are critical years, and all the more because we heard FASD also has some neurological and neurodevelopmental features as a disorder. So reducing the potential risk of complexity by cautious cannabis use. Where possible, to use products with low THC content and higher CBD. So looking at THC CBD ratios. And ratios are things we're really good at. And you don't have to have a degree in chemistry or engineering or the sciences to understand your ratios. We consider ratios when we cook. For instance, how much tomato do we put in and how much chili pepper? Now, if you had 80 parts chili pepper and 1 part tomato, that's very different to 80 parts tomato and 1 part chili pepper. And it's the same consideration with the THC CBD ratios with cannabis products purchased, and being sufficiently aware of that to make informed decisions. A lot of people aren't familiar with synthetic cannabis products such as, and they've got a whole range of different names, K2, Spice, and these are products actually made in the lab, but very potent on some of the cannabis receptors, and come in small packages like condom packs, very colorful. Many of them don't have a smell. Urine toxicology doesn't show them up in many of the standard urine testing, and people actually feel, oh, it's a cool different type of cannabis, or try to use this to evade testing processes. However, one of the significant risks of synthetic cannabis products is they're very tightly binding to some of the receptors and can cause very distressing symptoms, particularly amongst people who may not be able to give detailed accounts of what they consumed and how they consumed it. So to avoid these, and they come in many, many different forms. Smoking in any form carries a risk, and for those who may have concurrent physical health disorders, inhalation, and many of us have probably tried our best to avoid inhaling smoke from fires. And considering that and the risk of smoking to lung health, the lower risk guidelines would suggest avoiding smoking burnt cannabis where possible, and to choose, if need be, alternative methods of inhalation or edible type products. There'll be more warnings to do with edibles as well. Now we know vaping is going up and becoming more attractive. And one of the risks with so many of the vape products now is they smell really nice and come with different flavors. Cherry, mango, vanilla, citrus. And these are very addictive to so many people. And many vape products are now available infused with cannabis products. The risk that lies with this for some individuals is the risk of them being able to consume extremely high potency cannabis and dosing much higher than the person may find beneficial. So if cannabis is smoked to avoid harmful practice, and for those who smoke or observe smoking, not everyone smokes in the same way. Some people inhale deep, some people are shallow smokers, and there's a whole concept of smoking topography. How much of a drag does a person take in, or is it shallow? So people smoke in different ways, and through this process also load different doses of cannabis from the same joint. So one person can get 20%, 30, 40% of what another person may get from smoking just through their smoking habits. And a lot of people blow a heck of a lot of smoke with not much inhalation. So reviewing the smoking practice as well. Some of this is theoretical, but worth looking at. To avoid frequent or intensive use and limit consumption. And it was really interesting from Dr. Mela's slides, looking at the time of day people consume cannabis, which was evening, night, and into the early hours of the morning in that particular study. And in such a way that the cannabis consumption leaves enough functional lifestyle to be able to go to work or be involved in recreational activities or study and so on, particularly the person's experiencing adverse or side effects. Driving, this is a message that's been repeated over and over, and just reiterating not to drive and certainly not to combine alcohol with cannabis. So these are from the lower risk guidelines, and it's just to remind ourselves that this is the sort of information we have at the back of our pockets. Many of you already know, so my apologies for being repetitive. Recognize that people with a personal or family history of psychosis or substance use, as well as pregnant women, should not use cannabis if they can avoid it because of considerable risk of either harm to themselves or to the unborn child, or worsening various aspects of their own health and well-being, which we'll be referring to. And avoiding any cumulative effect. So if a person had one high-risk health issue or high-risk issue, combining cannabis and adding in an additive or multiplier effect to avoid that, to reduce the number of adverse outcomes. So that's just a quick whistle stop through the lower risk guidelines. And now touching on something that may sometimes contaminate FASD, diagnosis and quality of life, coming from what we refer to as the DSM-5, which is the major diagnostic index or diagnostic and statistical manual of mental disorders. So some people colloquially refer to it as the diagnostic Bible. And what I'll be doing is touching briefly on a cannabis use disorder. And it's important to think of this because a person living with FASD may unwittingly develop a concurrent cannabis use disorder that may also complicate some of their well-being. Not everyone, but it's worth being aware of. So some of the core diagnostic features will be use of cannabis for at least a 1-year period. I'll focus on the print in red. Difficulty containing use of cannabis with larger amounts used over a longer period of time than intended. So I just wanted to use some weed during my exams and I just can't stop using it now. Or I couldn't sleep for a few days and now I've been using it as my sleep aid for every single night for years and years. Number 3, repeatedly failed efforts to discontinue or reduce the amount of cannabis use. So the person there trying to cut back. And we heard some examples during the earlier presentation of people who had either stopped using or had cut down their cannabis use with a view to altering their well-being or improving their health outcomes. An inordinate amount of time occupied acquiring, using, or recovering from the effects of cannabis. And it's interesting that some of the studies, including those in the Canadian Cannabis Survey, observe that some people are under the influence or stoned 4, 5, 6, 7, 8 hours a day, particularly during functional hours of the day. And if this is occurring over and over, where the person spent a lot of time seeking cannabis, under the influence and so on. So look at how much impact that may be having their quality of life. Craving or desire to use cannabis. And sometimes we consider a crave to be, oh, I've got to get it now. But craving is actually more sophisticated and tricky in our brains. And by craving, we're referring to an immediate cognitive process, thinking of the substance in response to some cues. Continued use of cannabis despite adverse consequences from its use. And the person may have gone into trouble in their relationship, they've lost their job, their family are concerned, and the person still finds it difficult to modulate their use despite difficult consequences. And impact on activities of life, work, school, hygiene, and so on. It's worth we consider this, because if you layer these symptoms of a cannabis use disorder on FASD, then it can actually complicate the picture for a number of people and may, to some degree, in some individuals, impair their quality of life or alter some of their symptom presentation. Cannabis is used in contexts that are potentially dangerous, such as driving, the use of cannabis despite awareness of the problems, ongoing tolerance as in increasing the dose to get the same effects. And I'll be touching on withdrawal. And a number of people do experience withdrawal symptoms from stopping cannabis. It's not something that's talked about much, but there is a concept of a cannabis withdrawal syndrome as well. This is one of the tools used for evaluating a cannabis use disorder called a CUDIT. There's an audit for alcohol, and this is a CUDIT R for revised version. And this will be made available through Health Nexus, should anyone be interested in using this tool to just evaluate whether or not the person they support with FASD or themselves may be experiencing cannabis use disorder. Now, what I'm going to show in the next few slides is more of a theoretical framework, and it doesn't apply to every single person, but worth considering that there's a dose-dependent effect with cannabis. And in this, I started by saying there's no single cannabis, and I've been repeating the term, but in this case, I'm referring to THC, so delta-9 tetrahydrocannabinol, and there's a dose effect whereby the more the potency of THC, the greater potential of some risks in some individuals. So not everyone, some people use higher THC and may not show any adverse effects, but it's worth knowing that one of the potential tricky areas is the dose-dependent effect, whereby the higher the dose of THC in some individuals can create challenges. So we'll start with the diagram on the left. So either for recreational or medical purposes, it's used, and in the lower dose, some people report reduced anxiety. We heard that in the earlier study and presentation. Some people report improved sleep. Some people report being high, not in a way that's disturbing or distressing for them, but a sort of sense of well-being. I guess the word high explains itself. And for some people, pain reduction. Now, with the potency increased, the higher potency may have different effects. So here's an example. So because it's dose dependent, if the THC content continues to go up through potency or the root, and as we're aware, cannabis can be consumed through nearly, if there's any orifice of the body, cannabis can go through. So oral, it can be smoked, it can be applied. People now use through per anum and par vagina as well. But the routes of consumption may also affect how it's absorbed, the quantity consumed, the rate of consumption, and the tolerance. And this higher consumption in some individuals then interacts with individual endocannabinoid systems. And every single one of us has an endocannabinoid system. It's unique for each of us, and it continues to modulate through our lives based on our sex, our age, and exposure to various factors through our lifespan. We respond to cannabis based on different genetic factors and gender and others listed there. So this schema would suggest that at very low doses, THC in vulnerable individuals and some individuals can actually reduce anxiety. But if you rev it up a bit, can then become anxiogenic, as in trigger a bit of anxiety. And some people would report, oh goodness, I'll use that weed. I was chilled today, but today, goodness, I'm getting panic attacks. Now, for some individuals in much higher doses, then they may start feeling a bit paranoid and realize, uh-oh, I shouldn't be smoking 20-something percent, 28%, or using shatter. Shatter is a preparation that looks a bit like beeswax and can be up to 80-90% THC. And in those sort of situations, it's an indication to lower the THC potency. And in some people with very high potency, THC may have emergent psychotic symptoms or evolve into a psychotic illness, paranoid and psychotic, and in some cases, unearthing a schizophrenic illness. So summarizing some of the psychosis risks, they would come with frequent heavy use of high potency THC from an early age, particularly those with a developing brain, or with a history of mental illness and a family history of mental illness. Now, this gets considerably more tricky with FASD because this can lead to concurrent or comorbid health challenges for the individual. And it's incumbent on us supporting a person with FASD or with FASD to better understand what sort of cannabis products we're using and what is our safe limit. Why does it matter? Because 3/4 of mental health conditions have their genesis before the age of 24. So it's important where we can to have early interventions. And as people are achieving symptom relief or feeling comfortable in some spheres of their life, as Dr. Mela eloquently described with his slides and his presentation, that we also support them so that they don't sort of start a genesis of more complex health issues or mental health issues in the future. So a number of ways of reducing adverse events, which are mainly THC mediated, and in some cases can be rate limiting, so you slow down or you stop and the adverse events reduce, would be the basics. And you would have probably heard this many times over, but it's worth reminding ourselves to start low. So if you're a novice to cannabis use or you don't have long-standing experience with cannabis use, and you're trying to know what your gauge is or your dose is that you're comfortable and safe with, then to start with the lower numbers of THC, preferably with CBD, and gradually build up. And in a sense, some of the cannabis products available through legal sources do allow for that, because you can start with smaller edible doses and build up, or smaller smokable products and build up gradually, so you're familiar with what works best for you. Now, we're very early in our cannabis knowledge in health systems, and we're way, way, way behind alcohol. So dosing and what's a standard dose of cannabis is still something we're going to need to gradually get better at. And that's why we need to do so much more research in that space. It's taken centuries for us to have that coding with alcohol, and we're going to need to work very quickly, even quicker now. So an example would be, for alcohol, you have the labels, how much alcohol is in it, but also the containers we use to consume alcohol have adapted to the potency. So the more potent the alcohol, the smaller the container that we use to drink it. So spirits go in little tiny shots, and people drink them in shots. And then the wine in a slightly larger vessel, and then beer in the bigger vessels. Now, if a person drank vodka from a beer mug, that may be problematic. And we're still adapting to, okay, so what are the right doses? What are the right containers? How do we develop a cannabis etiquette for individual safety? Now, some people may say, well, if cannabis use is problematic, then just stop suddenly. But I'd caution here, because stopping suddenly, particularly with someone with a cannabis use disorder who has become very dependent, there's the risk of developing a cannabis withdrawal syndrome. And the next slide will really highlight how much this relates and can be relevant to people with FASD. So there are many situations a person may actually stop cannabis use, not voluntarily, but because they've had to go into hospital or emerge, or they're in jail or under the criminal justice system, or they have not had access to cannabis by virtue of the location they're in, or their supply routes have been impaired, and so on. And I'd like to go through, I'll focus on particularly the B component here, because if we reflect on this, how much of this may overlap with some of the symptoms people with FASD live with? And if, for instance, I had FASD and I went into hospital with concerns about my mental health, and I didn't have access to cannabis, and I was going through a cannabis withdrawal, I might become considerably worse in hospital. And I'll suggest, particularly easier now because cannabis is legal, that if a person needs to go into a setting or location where they no longer have access to cannabis and they're cannabis dependent, so please let the professionals know, because some of these withdrawal symptoms may mimic or exacerbate other health conditions or mental health conditions. So for some people with cannabis withdrawal, they may become increasingly irritable with anger and aggression. And imagine that on a psychiatric unit after a person's been there for a few days. Some may become more nervous and anxious. Some may develop sleep difficulties with insomnia, disturbing dreams, changes in their appetite, restlessness and agitation, depressed mood. And a number may also go through some physical sensations. Not everyone, but a number of people do. Abdominal pain, shakiness, tremor, sweats, and so on. Now, for a person with FASD in hospital or in a correctional facility or in the emergency department for a period of time, going through these, you can see how this may sort of mimic or exacerbate or confuse the diagnostic picture. So if you use cannabis, please let people know so that they have a bit more clarity in their decision making. Talking of techniques, so if one can do without going cold turkey, particularly if it's a chronic heavy user, one of the techniques may be to gradually reduce the THC content. So from using shatter at, let's say, 90% THC, 80-something%, and gradually cutting down the THC content. as we heard one of the people Dr. Mela referred to successfully doing. Another way of adapting to that also is then increasing the CBD content. And this can allow for a smoother land. So think of like landing an airplane. So just gradually titrating and coming off so that the person doesn't go through distressing cannabis withdrawal syndrome. As I said, not everyone develops it, but the risk is there. Reminding ourselves there's no single cannabis, then several cannabis products, and the implications of that are that we can't generalize. So this is a study we've been carrying out, looking at licensed products and what is a joint. And we looked at cannabis THC potency of individual joints, and this is markedly variable. So no single joint has exactly the same amounts of THC. Some joints are nearly 200 times more potent in THC than others. So it's really important to familiarize with the numbers on the label, because a joint is a very unreliable unit of estimating cannabis use. Now, quick example here, this is a package, no endorsements, but I'm going to draw your attention to some of the wording. Now, on many packages, you'll see words like THC per unit and total THC per unit. And it's very important to understand the distinction between these, because a lot of people will look at the THC and may say, oh, it's just 3.45. But then the total THC here is over 80%. And what's the difference? Now, total THC actually isn't the amount of THC in the package. And I'll explain, some of you may be familiar, but I'll just explain for clarification. So THC is the dried flower unburnt, because to activate THC from the acid form to the active form of THC, it needs to be combusted. So THC on the package is just uncombusted, and total THC is when you then burn it, this is what it gets to. Another way of looking at it, and if you're into cars, think of THC, your standard number, as the car just idling away in the car park, moving at maybe 5 kilometers per hour, just at rest and idling. And then your total THC is the fastest speed that car can go on the motorway under the best conditions. So it's really important that we're familiar with the distinction between THC and total THC. Some people think, oh, well, I'll just use in low potency with just 3.45, and then they light up and have a completely different effect. So moving on closer to the end, managing problematic cannabis use and adverse effects. Not everyone, and referring to some work done by our colleagues in BC and some others, but some of the common adverse effects of cannabis use will then be related to drowsiness in some people, fatigue. Some people may feel dizzy because of blood pressure changes, a dry mouth, the cough, bronchitis, particularly from smoking. Some people may develop anxiety symptoms, some nausea, cognitive effects. And cognitive effects is an important one, and anxiety if we think of FASD, because how does this also overlap with a person's underlying illness or condition? Some people may be euphoric, and euphoria on its own isn't a mental disorder, but sometimes if it's excessive, can be problematic, and in some areas can mimic a mental disorder known as mania. Some people may have blurring of vision, and some experience headaches. And then there's some rarer ones, such as hypotension, the blood pressure going down, a person becoming floridly psychotic, paranoid. Some people may have mood effects and become depressed. Some may have unsteady gaits. A number of people may have a much more rapid heart rate and hyperemesis. Now, people hear that the cannabis is used to reduce nausea and vomiting, but the evidence is actually nausea and vomiting in people with chemotherapy in cancer care, and not nausea and vomiting in pregnancy or after having food poisoning and so on. And there's something referred to as a cannabis hyperemesis syndrome. And this is a syndrome where people wake up or with cannabis use retching and vomiting. Some people in lay terms refer to it as greening out. And a number of people observe that after a hot shower or other process, that this reduces. The hyperemesis is certainly one to think about quite seriously. Another may be diarrhea. And in some situations, the person can't even attribute it to the cannabis used. So they use cannabis, they're having symptoms, but they may not be able to make the link, or depend on the severity of their FASD symptoms or deficits, may not be able to explain or attribute this. For those working with individuals with harmful cannabis use or who may be wanting to consider reviewing their cannabis use, I present to you here a cannabis contemplation circle, and this is really for motivational conversations. How much does the person feel cannabis is a problem? And the different numbers, do people want to change the way they use it, and why do they want to change it? And if they want to change it, support for how to. And it recognized that people may still go back to cannabis use, but an opportunity to modify use if it's harmful or problematic. And this can be made available to any of you interested through Health Nexus. And when it's being applied, to ask for each of the different cannabis products, people may have different motivations to change. So I may wish to stop smoking cannabis. I just want to stick to edibles now. So I might want to reduce my smoking, but continue with edibles or vaping and so on. So looking at the different types and not sticking it, maintaining just with smoke products. And a reminder to all of us, stating the obvious, when you're asking people or engaging conversations about cannabis, don't limit it to smoking. All too often people ask, oh, do you smoke cannabis? And the person says, no, no cannabis use. And the person may be consuming huge quantities of edibles. So the stages here have been sort of color coded. And once again, this can be available if you're interested from Health Nexus for your own day-to-day work or practice as well. So moving close to the end, just highlighting the complexity of consuming cannabis and cannabinoids, knowing that in Canada, cannabis is not prescribed, it's authorized, but not prescribed. So no one gets a medical prescription. There's an authorization given by a physician or nurse practitioner to acquire cannabis products. And for those acquiring for medical purposes, I would encourage to let them know, whoever it is you're working with, know that you have FASD, the type of symptoms you have, so they can make informed assessment and decisions with the recommendations regarding what sort of products may be safe or not. So some people may get an authorization of a certain number of grams a day or week with emphasis on low THC or high CBD and so on. Cannabis and cannabinoids, which is the greater range of the whole pool of different chemical compounds in cannabis, well exceeding 100, of which we only know THC and CBD better, they act in different ways. Each of us has genetic differences, and the way we interact with cannabis is also quite different. Another complexity is that we metabolize in different ways. And again, we don't need to be scientists to know that. If you give 10 people a glass of wine, they may respond differently. One person may consume the wine as if they've not consumed anything. Another person may get giddy on a glass of wine. One may get irritable and angry and start fighting. Another may giggle. So we all have individual differences in the way we respond to chemical products and substances like cannabis, alcohol, and so on. Does the person have prior exposure, pharmacological tolerance, as mentioned earlier? Other complexity, does the person have a previous or concurrent medical disorder? And if so, are they on treatment for it? So if I'm on an antidepressant or an antipsychotic or sleep medication or under cancer care, and I have FASD, how will the cannabis fit with all of that? Variable potency, no single cannabis. It varies. And which cannabis are we talking about? Furthermore, which ratios are we talking about? Dosing regimens, the time of the day, how much THC, how much CBD, what routes has been taken, and this adds to the complexity. Even for the research and studies that people carry out in this space, what cannabis are we talking about? So as we move to the close to the very end, here's an example of the differences in smoked and edible cannabis products. So here we have the edible ingested, with the time it takes for the onset of action, and then the time it takes for it to peak and the duration of action for an edible is considerably different to smoked products. And that's really important to remember, because if we look at this webinar, the first few slides of Dr. Mela's presentation, if it was smoked, some people would already start having an effect. While with an edible product, some people are just beginning to feel the effects over an hour in. And the duration it may last, for some people then half an hour, and other people several hours, and in some cases days. We sometimes hear people who ingest cannabis products and feel fine and wake up stoned. So it's really important to understand that there are different onset, peak, and duration for different types of cannabis products for each individual. And it's important that we familiarize with this, particularly as we live with FASD or support people with FASD. So in conclusion, I start with my early slides. There's no single presentation for FASD. There's no single cannabis product. Self-awareness matters. Cannabis awareness matters. And cannabis can be associated with individual benefits and harms, depending on who. So in summary, we've heard about cannabis in FASD. We've had some presentation on safer use guidelines, and also hopefully a better appreciation of the complexity when we refer to cannabis, what it is, having a better recognition of what may be authentic or legal cannabis products and non-legal, and also an awareness of the complexity of the numbers, THC, CBD, and the implication in day-to-day cannabis consumption, knowing that no size fits all. Each person may be different, and the fact that Deji used cannabis and felt fantastic on it doesn't mean Deja would use cannabis and not become psychotic or feel worsened. So each person, know yourself better, know your safe limits, and trust professionals or seek professionals who have sufficient awareness of cannabis in these important conversations as you find the best route to your own health and wellness. Thank you.
Thank you so much for your presentation.
Or maybe Dr. Mela is going to then punish me with a few questions.
Absolutely.
Yeah, no, thank you. This
I can
excellent. Hear you. Yeah. So I'm sure the audience is, I mean, there's so much to learn about the individuality of, anybody, but then add, as you said, Dr. Ayonrinde, about the complexity that FASD brings. I think I'm just wondering, in terms of the experience of people who are actually trying to reduce, do we have any information about that method of reducing the THC and increasing the CBD? I can see it working perfectly in the context of the motivational contemplation chart, which was excellent to see as a clinician. But do we have any evidence of what it takes to actually do that? Because that's one of the resistances I find, even though few people talk about the difference, but that lack of knowledge, how do we actually get them to do it and reduce that amount?
Thank you. Well, in my clinical practice, I really take time to know the numbers, and I like seeing people's weed. Um, Thankfully, I work in a premise that allows for that, and if not, if they can take pictures, because we can look at the numbers. And on the basis of the numbers, we can then compute. For instance, there's someone I'm working with who consumes close to, well, what the person purchased was up to 800 milligrams of different preparations, gummy bears, vape. She loved the flavor of the vape. The gummy bears were tasty and so on. And she was in a perpetual state of intoxication, but sleeping well. And people are willing to tolerate one desirable effect if the other less desirable effect doesn't cause them serious harm.
Right.
There was, yeah, okay, my days aren't as good, but I now sleep really well. And I think it's incumbent on us as health professionals, those who support people with a range of needs, to be better informed ourselves. What are these numbers? How can we actually now use science, as we do for medication doses and so on, to guide people? There was someone I was working with who was using shatter and amnesic, just couldn't remember anything every morning. And when I explained the potency of what the person was using, it was, oh my God, I never knew. And the person was then able to tail down and still continue to use cannabis in a sociably acceptable way for the person without the amnesia. So I think it's incumbent on us to now get into the space with the numbers, really get green in these conversations. And the days of a doctor or health provider saying, stop using cannabis. And likewise, for the average frequent or informed cannabis user, within 2 minutes of, in fact, maybe 1 minute of speaking with a health professional, they know if the person knows anything or they're not. And many that straight away, they lose confidence. That person didn't even know what they were talking about. And we're not talking about finer details like terpenes, the unique aromatic smells, you know, myrcene that smells like mango or like lavender and so on. So cannabis knowledge is getting more sophisticated. I would say our knowledge in this space, we need to start looking more at how the coffee industry is. You know, you go into coffee, you're buying a coffee and how much coffee, how large do you want it? Even your coffee purchase in some of the coffee shops, the size of the container will help you with your dosing. And then the potency of the coffee in it will help with your dosing. And then you can add your ratios of milk, sugar, whether you're doubling or not, and so on. So we already have a way of doing this in other spaces, and we need to bring this sort of etiquette and literacy and understanding into the space of cannabis so that we can drastically narrow the time it took for alcohol to go to where it is. Tobacco is easier because, you know, they come in sticks. It's for cigarettes, it's a pretty standard, or even then, nicotine doses are different. Right. So we have a lot to do, but we have to do that work and come out of the smoky shed and smoke it in the bush or a bong hidden under the bed and talk more about it as we build the new knowledge base.
Yeah, that's great. Yeah, thanks.
I see that we've received a few questions. One of them is, do you see a future with future time, when CBD dosages will be regulated and controlled use?
CBD is a very interesting one because if you go into any magazine store and shelf, you've got CBD for everything. And I think we need to start knowing a lot more about CBD. There's good enough evidence that CBD does not have the sort of effects THC has. and whether uniquely separated, just pure CBD products in the long term will remain in that sort of category. We're yet to see. It's looking promising that CBD is growing in its potential in different spaces, and the science will guide us. I think if the science can guide us with regard to harms or lack of, where it's not CBD contaminated with high dose well, I would draw the word contaminated, but CBD mixed with THC, which may then confuse things, then I see potential, recognizing fully that there's still many other cannabinoids we don't even know much about. So it's the equivalent of attending an orchestra, and you know the guy on the drums, and you know the guy on the saxophone, but there's a whole orchestra playing. We just don't know who the other guys are. And we may realize that actually the most important person in the orchestra may be someone else, maybe the conductor and so on. So there's a lot we don't know, and hopefully we will with time.
Another question was, is there any research into alternatives to cannabis that can achieve similar desired effects that cannabis does for individuals with FASD?
Thank you, Karen, for that question. Now, where that's tricky is there's no single FASD, as said earlier. And what we heard from Dr. Mela's presentation is some people are trying to achieve unique symptomatic benefits, anxiety, sleep, stress or tension, and so on. And I think there needs to be a lot more research in that space. A lot of medicine doesn't promote more and more and more medication. Less can be more. So much more research to be done. Hopefully Dr. Mela and many others get their research grants, so we'll know soon.
Thank you. And one last question before we wrap up. Someone was asking, do you find a correlation between trauma and cannabis use? How do you navigate that?
Fantastic question. My pressure is to answer this in about 60 seconds. A lot of people living with trauma do not like it. Living with trauma, particularly when trauma is in high definition, crystal clear like PTSD, a lot of people naturally want to fog that trauma so it's not clear. Change it from crystal clear high definition to black and white or fog. So it's very natural for a lot of people living with trauma to do whatever they can for trauma not to be vivid. And it'll be a natural process to seek a substance, alcohol, cannabis, opioids, and other substances to reduce that. There are other interventions that aren't DIY, and hopefully mental health services and other services and carers can work to support this. And in the spirit of primary prevention, where we can, also to reduce trauma in the first place, if we can. Fantastic question. It's difficult with 60 seconds.
Absolutely. Well, thank you both for your time and both of your wonderful presentations. And thank you to all the attendees to make time to participate in the event. Have an excellent rest of your day.